As a medical provider, you're probably getting tons of questions from patients, family, and friends about Tylenol and autism. So in this video, I want to clarify what we know about acetaminophen in pregnancy, what we don't know and why those gaps matter, and some of the dangerous unintended consequences this premature public statement is likely to have, what you can safely tell your patients today, and how to document your conversations to defend against liability. Now, it's prudent here for me to mention that this content is for educational purposes for healthcare professionals. It is not personal medical or legal advice, and you should always consult current guidelines and institutional policies when treating patients. So let's begin by talking about what was said and why this became news so fast. Trump had specific statements about acetaminophen, including, "Don't take Tylenol, fight like hell not to take it. Taking Tylenol is not good. I'll say it is not good." Now, when challenged, he acknowledged that his advice was based on his common sense and his personal feelings, rather than solid scientific data. But that forceful, non-qualified language is part of the reason why this is such a big news story and why it's so unsettling. So let's dig in and see whether the data supports that level of certainty that he seemed to speak with. Now, over the last decade, a number of observational studies have reported associations between prenatal acetaminophen exposure and neurodevelopmental outcomes like autism, ADHD, and other cognitive or behavioral effects. Some do show small increases in risk, others show none. One of the largest studies done is the Swedish study with a cohort of over 2 million children. They did find that acetaminophen use was modestly associated with autism, but, and this is key, when they used sibling control analysis, the associations disappeared. Now, what does that mean? Well, it means that researchers compared siblings where one pregnancy, the mom used Tylenol, and another one, she didn't. And once they did that comparison, the link with autism and ADHD disappeared. That suggests that it wasn't the Tylenol itself driving the earlier association. That incredibly large study is the strongest piece of evidence that we have, and it undercuts the idea of a clean causal link between acetaminophen and autism. Now, it's also important to understand the limitations of observational studies. To interpret the data responsibly, you need to know the key caveats. So besides the confounding elements, observational studies often suffer from exposure misclassifications. Many studies rely on maternal recall or prescription records that don't actually capture the over-the-counter use accurately. Also, dose and timing data are poorly characterized because many studies do not reliably record how much acetaminophen was taken, when it was taken during the pregnancy, and for how long. But let's disregard those problems with the studies for just a minute and look at the results and see if they show any strong indications. Even the most positive studies show small relative risks, and those findings are not even consistent across populations or methods. So any associations we see are weak at best and certainly do not equal causation. That is the core scientific principle that we must stress in any patient or family discussions that we have. And it's worth reminding patients that if strong evidence ever showed that medication truly causes harm, we wouldn't keep recommending it. As clinicians, we don't profit from whether someone takes acetaminophen or not. We've devoted our careers to helping people, and we've taken an oath to do no harm. It's also important, though, to remain humble, not lose your temper, and admit what we don't know. We do lack any randomized prospective trial to test causation. We don't have robust dose response or timing data, like when in gestation it's safest to take, how much we can actually safely give, and for how long. So given the data and the gaps that exist, I feel any strong public statement that Tylenol causes autism was scientifically premature. And I also think this announcement was dangerous. Why do I think it's dangerous? Well, because I believe it will produce some unintended consequences that could cause real harm. One of those is inappropriate substitutions will happen. Pregnant patients who don't know any better may switch from over-the-counter acetaminophen to over-the-counter NSAIDs like ibuprofen or naproxen believing that they're safer because, the president didn't talk about those. But those drugs do have known fetal risk, especially after 20 weeks gestation. Also, women may be too afraid to treat, or they may undertreat their fever or their pain, elevating risk to mother and baby. And then there's heightened anxiety, especially from women who are currently pregnant who may have taken some Tylenol in their pregnancy. Pregnant women are already anxious about their pregnancy and concerned for their child. This may cause them additional stress and anxiety, which can have a very real and negative effect on both the mother and the baby. This announcement can also cause them to lose trust in their clinicians, which can lead them to ignore other critical medical advice. There's also the danger of these kinds of announcements further eroding just general public trust in medical science, which can lead to other unintended harmful results. So what can we do? What should we do? Well, we need to counteract these statements with clear evidence-based counseling. To help you do that, let's review where the major medical bodies stand on this topic. So ACOG, the American College of Obstetricians and Gynecologists, continues to support acetaminophen use in pregnancy, if needed, in moderation, and after clinical consultation, which I think has been their guidelines all along. Society for Maternal Fetal Medicine, SMFM, continues to support acetaminophen use and have concluded that the evidence against acetaminophen in pregnancy is insufficient to change current practice. The Society of Obstetricians and Gynecologists of Canada reconfirmed that acetaminophen remains first line for pain or fever in pregnancy. Well, the FDA on September 22nd initiated a process to update labeling to reflect possible associations, and they issued a letter alerting physicians. They clarified that acetaminophen use in pregnancy may be associated with neurological risk in some studies, but it did not declare causation. So the bottom line is that most major medical bodies are not endorsing the dramatic claims and not changing their recommendation, with the one exception of the FDA saying that there may be an association. So what are the practical guidelines for clinicians? And what do we need to think about and what do we need to do? Well, the first thing is that you need to remember that untreated fever and pain in pregnancy have very real risks. The risks from fever include miscarriage, neural tube disruption, growth disturbances, and increased risk of other adverse outcomes. Pain can be dangerous because it can disrupt sleep, leading to exhaustion and depression in the mother. It can also interfere with women's daily functions. Maybe they're not eating as well or caring for themselves, which then has an indirect effect on the fetus as well. And then, of course, pain and stress can activate catecholamines that can constrict uterine blood vessels, reducing blood flow to the placenta. It's also important to remember that we are not aiming for zero pharmacologic risk. Just like with any medication, we're balancing known risk of fever and pain against theoretical or poorly quantified risk of the drug. So here's one evidence-aligned approach that clinicians can use when considering acetaminophen. The indications to treat: fever over 100.4 or 38.0 degrees Celsius, moderate to severe headache or musculoskeletal pain interfering with function or sleep. Use the lowest effective dose for the shortest necessary duration. Avoid prolonged repeated dosing unless absolutely clinically necessary. Now, if possible, consider non-pharmacologic adjuncts. These would be things like adequate hydration, rest, cool compresses or tepid baths, lukewarm water, not ice water if you're trying to reduce fever, and then topical treatments when safe. So like topical heat or cold or massage for musculoskeletal pain. And of course, that crucial reminder for yourself and for your patients: do not substitute NSAIDs like ibuprofen or naproxen in place of acetaminophen, especially after 20 weeks, because of the known fetal risks: fetal renal injury, low amniotic fluid, and risk of ductus arteriosus constriction. And of course, remind patients to call or come back in if their symptoms persist beyond 48 to 72 hours. Now, from the legal or risk management perspective, make sure that you are careful with your documentation in your clinical note, and as always, stay in line with your institution's protocols and policies. So if you prescribe or even just recommend over-the-counter acetaminophen, be sure to document what the indication is: fever, headache, pain, the dose and duration that you recommend, and then the counseling that you gave the patient regarding the risks, benefits, and alternatives. And it wouldn't hurt to mention the guidelines or society positions that you referenced, like ACOG or SMFM. You can make a quick dot phrase so that you can easily put those into your note. And also when talking to the patients, try to avoid absolute wordings, like don't say safe or unsafe. Instead, use phrasing like the benefits outweigh the risks when used as directed. And if a patient still declines acetaminophen, especially in the face of fever, be sure to document that you explain the risks of untreated fever in pregnancy and what those risks are, that the patient still declined, and then document what alternative plan or mitigations you discussed, such as those non-pharmacologic cooling methods, monitoring when to call back, etc. This documentation helps show that you engaged in informed evidence-based decision-making with your patient, even when the patients make a different choice. And if you're curious how Trump's so-called big, beautiful bill will affect and change healthcare, then check out this video here. Thank you for joining me, and as always, take care, stay sane, and I'll see you next time on the Medicine Couch. Bye.